That's an excellent question. Everybody has nicotine receptors. Even if you've never smoked a cigarette, never seen a cigarette, you have nicotine receptors. You have them in your brain, you have them in their body, they serve different purposes, so they're not bad per se. It's just that nicotine, when it's ingested from a cigarette or from other sources, can kind of take things awry. And so babies are born with nicotine receptors. And we talked about upregulation, so there are more receptors the more you use. It's not like the first time you smoke a cigarette, all of a sudden there's a blossoming new crop of nicotine receptors in your brain. It takes time, it takes some exposure. And yes, if you stop smoking, those nicotine receptors, when they're not being used, they do sort of degrade and disappear. And so we have research that shows that. So this is something where even though you are addicted at one point in time, by stopping the drug, you do have the power to change the way your brain is wired, and that in turn will help you continue to live life as a non-smoker or as a non-drinker. With respect to the baby's going to be born with nicotinic receptors. I'm not aware of any research that looks at the amount of nicotine receptors in babies, but we certainly know that with drugs of addiction, some babies are born and their body is addicted and they go through withdrawal, and that can happen. I am not aware of any evidence that that babies born to women who smoked during their pregnancy or drank during their pregnancy actually go through withdrawal or have any sort of negative consequences when they are born.
I personally haven't come across any evidence that shows that it's unsafe to quit cold turkey during pregnancy. I think that's a myth that's perpetuated, but I think quitting cold turkey during pregnancy is healthier for the baby than having all the chemicals of cigarette smoke crossing the placenta and everything like that. So I don't know if you have anything to add, but
I would also add, there is absolutely no evidence that babies who are born to women who quit smoking have any sort of health problems relative to babies who are born to women who continue to smoke. Women who continue to smoke have babies that have lower birth weight and all the attendant problems. They have shown some psychological issues. Think about all the women that you see who were smokers, they found that they were pregnant and they quit. They quit cold turkey in the first trimester, right when most development is happening, and there are no problems or side effects.
Well, I think Dr. Piper will probably have a little bit more background, but I can take the initial stab at the question. I think smoking when you're stressed, because stress kind of ramps up a lot of the cortisol and the hormones in your system, just by that's physiologic nature. Some of the changes that happen during the addiction process in the brain kind of make you more susceptible to having those hormones ramped up and what those hormones do. So there's actually a couple of schools of thought that when you have lots of cortisol, so when you're stressed out and you're producing lots of stress hormone, you're going to want to reach more for that cigarette to kind of get that dopaminergic surge. And then it's kind of the same thing when you don't have any of that stress hormone. Sometimes that makes you more apt to smoke as well. But I don't know if you have a better explanation for that.
Sure. I think it has to do with, we talked about negative reinforcement and the idea that when you feel bad, and that could be from withdrawal, your body says, oh, feel bad, reach for a cigarette. Okay? And so when you're stressed, oh, feel stressed, reach for a cigarette. Now, nicotine is a stimulant, and you think, well, how is that helping you calm down? But one of the things that we've known, actually from our research, we've started to see is that people sometimes, even in anticipation of going to smoke, start to calm down. Their bodies are like, oh, I'm going to get the drug. Now I can start to relax because I'll get what I need. And if you also think about, again, the ritual of smoking, part of it's getting the drug to your brain, and part of it is what you do. Most people have to step outside. So I'm involved in some really tense, heated discussion, and I'm really stressed out, or I just hung up the phone with somebody. I physically remove myself from the situation. I go outside, I take some deep breaths, let them out, and I try to relax. Whether I'm doing that with nicotine or without nicotine, those are helpful coping skills. So if you're talking with somebody who has a lot of stress in her life, and my kids make me nuts, and all I can do is escape outside so I can have a cigarette. Well, anybody would want to escape outside when their kids are making them nuts. And that is a good coping strategy. We want people to do that. Can you escape outside and have a piece of nicotine gum? Use a lozenge. Just sit out and do some deep breathing. Sometimes smokers will cut up straws so they have something to breathe through. Sometimes they'll chew on cinnamon sticks. But again, it's not staying in the situation. It's taking the break, trying to calm yourself down, trying deliberately to calm yourself down without nicotine, or at least in the form of a cigarette, and then returning to the situation. So yes, it reduces stress, but then your body is going to go through that same deprivation cycle. Oh, now I don't have enough in my brain again. Oh, now I need more cigarettes, and now my stress comes back up.
Well, generally what I tell patients is we don't have a lot of evidence on long-term effects of e-cigarettes. They don't have as many chemicals as the traditional cigarettes, so I think the folks at C-Tree are saying that they are better in that respect, that they don't have the 7,000 chemicals, they have a couple. From my standpoint as a physician, I am worried that they may not be effective quitting devices. I don't think that there's been enough research yet to prove whether they are or they aren't. And it does make me nervous that people could start using e-cigarettes and transition to regular cigarettes. As far as using them in pregnancy, I would strongly discourage that, again, based on the fact that what little evidence we know in non-pregnant people with e-cigarettes, we have even less, if any, on pregnant patients with e-cigarettes. So I wouldn't feel comfortable having any pregnant patient use an e-cigarette. I would more want them to use the nicotine replacement therapies that have some evidence behind them in pregnant patients. And then in non-pregnant patients, I guess the best I could say is hopefully they're healthier for you, but we don't have the evidence really to prove that.
I think e-cigarettes comes up as an issue, in addition to the points that Dr. Berg made. A couple of things to think about. They're seeing a real increase in poisonings from children getting a hold of e-cigarettes. So that's something to be very aware of if a woman is deciding to use that, if she's got other children in the home, especially toddlers in that age. Nicotine is fatal in large doses, and I'm not sure people understand that because they know we can consume it and we can sell it over the counter, but if kids get a hold of it, it can kill them in large enough doses. Especially a little juice, they call it the juice that goes into e-cigarettes. Juice vials, if somebody were to actually drink that, it would kill a small child easily. I think another point to make is if you're truly trying to quit, and this is an issue for women smokers who are pregnant, they don't usually think about it as quitting. I'm going to take a break for the next 7 to 8 months, and as soon as that baby is born, I will be back smoking. So if I can use an e-cig and it's safer, then I don't actually have to give any of that up. And really, again, if we want what's very best for the baby, that's no nicotine and not the 6,999 other chemicals, but we're talking 4 or 5, it does become a trade-off. And the other thing to think about though is depending on what e-cigarette you're getting. So a lot of e-cigarette manufacturers are in China. We don't know what is in those e-cigarettes. We have no idea what additional chemicals are involved. And so really wanting to be very careful about what you're using as far as an e-cigarette choice. If I had to weigh the odds and be practical and talk to a woman sitting in front of me and she says, the only way I'll give up regular cigarettes is if I can smoke these e-cigarettes. I know for sure e-cigarettes are bad for you. I don't know for sure anything about the e-cigarettes, and that's going to have to be her choice about what to use. But I do know for sure what's in mini lozenges, nicotine gum, and I know that those are things that can help you with cravings, and they're going to be much safer, and I know more about it and feel more comfortable if you use the evidence-based medicines as opposed to the e-cigs.
it's a great question. It is a very difficult topic. I think some of the key things, establishing a relationship with the patient. So, some of the things that making sure you're sitting at the patient's eye level so that you're not standing and looming over them. They're not on the exam room table or anything like that, and you're looming over them. Taking off the white coat so that you're dressed similarly, you don't have that stigma on. I like to get to know them a little bit. I try to have some sort of just general conversation, whether it's about the weather or the Packers or the Badgers or something like that, just to kind of establish a little bit of rapport with the patients. And then sometimes if it's a particularly sensitive topic, oftentimes I'll say, it's a tough topic, but sometimes my patients will tell me that they're using alcohol when they're pregnant and they would like help with that, or they're using other drugs, and I just want you to know that this is a safe place. I have options, lots of different options that we can discuss for help and getting you help for whatever it is that you bring up. And so kind of normalizing it, letting them know that they're not the first person out there that's ever used alcohol or tobacco when they're pregnant, and kind of allowing the establishment of that safe place.
Yeah, I think that sounds like a fabulous approach. And I think one thing that you can also talk about is, sometimes providers don't want to have those hard conversations, and so they try to skirt the issue. They don't want to talk about it. I'll ask you this question, you said no, fine, I'm done. But research shows that the doctors who ask the hard questions, the doctors who talk to their patients about their smoking, who talk to their patients about their drinking, are viewed as more compassionate, more caring, and better doctors. And so if you can say, and maybe it becomes saying straight out to the patient, now we're going to get into the part that's hard, okay? And I'm asking you these questions and we're having this conversation because I care too much about you as my patient to not have this hard conversation. The more honest you can be with me, the more helpful I can be. But I know for a lot of my patients, that's a hard thing to do. Sometimes people feel embarrassed, or they wish they didn't have to do this, or they don't want to tell some other person their private business, which, I could certainly understand. But what I want to do is try and encourage this to be a space where I am asking you to tell me your private business, and I know that. Sometimes people may have concerns about whether authorities are going to get involved, whether Child Protective Services is somehow going to come and get involved and take other kids or, do something to them. But the idea is the information you give me is to help me help you. It doesn't go anywhere else. And so that's another thing I think that can be helpful. But also saying, as a doctor, this is my job to have hard conversations, and that safe space you're talking about I think is invaluable.
Mm-hmm.